Welcome to Ego Over It, the psychology of everything, where we explore the science of what makes us human and the stories that make us feel it. I'm Dr. Austin Attaway, an organizational psychologist, professor, and mental health advocate. Each episode will explore the psychology behind our everyday lives and the complexities of our experiences. Whether you're here to understand yourself, others, or the world around you just a little better, you're in the right place. This is where research meets real life. So grab your coffee, take a breath, and let's dive in. Today, we're taking a step back and looking at the big picture. This is our state of mental health in 2026, where mental health care in the US actually stands right now. Not just the headlines, not just the hot takes, but what the research says, what's changed in care, where the pushback is coming from, and how to make sense of the misinformation that's everywhere. If you felt like everyone is struggling and also like everyone is arguing about how we talk about mental health, you're not imagining it. In 2026, mental health care in the United States is in this weird in-between. There's more awareness, more tools, more demand, but still huge gaps in access, trust, and quality. Today, I'm going to give you a big picture snapshot, what the data says, what's actually changing in care, what people are pushing back on, and how to spot misinformation without becoming cynical. I do want to make a quick note before we get started. This episode is educational. It's not medical advice. If you're in crisis in the United States, you can call or text 988. I would also like to provide a brief trigger warning as we will be discussing concepts, themes, and information around suicide. Now, let's start with the adult landscape. A simple way to frame 2026 is that mental health need is widespread, and it's not a niche issue anymore. Recent national snapshots show that roughly more than 1 in 5 adults experience some form of mental illness in a given year. For example, Mental Health America reported that 23.4% of U.S. adults experienced any mental illness in 2024 and in 2025. That's about 61 million people. Now, that doesn't mean that 1 in 5 people can't function. It means 1 in 5 people met criteria for something diagnosable in the past year. This can range from anything that's an anxiety disorder and depression to more severe conditions that do inhibit day-to-day functioning. But if we zoom in on depression specifically, CDC data shows that depression prevalence has increased over the last decade plus. One CDC report shows that there is a 13.1% prevalence from August 2021 to 2023, which is up 8.2% since 2013 and 2014. That's a significant increase in the prevalence of depression. But here's the line that matters for care. Need and prevalence do not automatically translate into treatment. In this same CDC report, among people 12 plus with depression, only about 39% reported receiving counseling or therapy in the prior 12 months. That's 60% of people not receiving care, support, or services that they need. So when you hear that mental health awareness is up, you can translate that as more people can name the problem, but many still can't access effective help consistently. Now, I do want to talk about youth. There's trends that have been pretty alarming, and we're also starting to see some mixed signals. The CDC runs an annual youth risk behavior survey. Last year, it showed that 39.7% of high school students experienced persistent sadness or hopelessness, while 20.4% seriously considered attempting suicide, while 9.5% did attempt suicide. Now, it's important to note that the CDC is trying to improve not just its reporting, but the quality of the data that it collects, especially among female students and Hispanic students, because generally those populations are underreported and have higher prevalences of hopelessness, sadness, other depressive symptoms, and contemplation of suicide. Now, preliminary CDC reporting, as covered by the Associated Press, does indicate that the U.S. suicide rate fell in 2024 to 13.7 per 100,000. Now, that translates to about 48,800 deaths, a lot, but also 500 fewer than the prior year. Now, that's not a victory, right? But it's also not nothing. It is still a decrease. Now, that's the vibe that we're kind of going into here in 2026. Still a crisis, but not a flat line of doom. We're seeing both serious risk and signs that interventions and funding can move the needle. So, what's changing in care in 2026? Here's the headline that I want you to know. Care is expanding through technology and better policy, but access is still constrained by workforce and infrastructure friction and issues with insurance. Let's start with telehealth. Behavioral health, telehealth, mental health care through something like Zoom, right, or Simple Practice, many platforms that provide it. This is no longer a pandemic-only experiment. The HHS's telehealth policy updates note that these Medicare behavioral and mental health telehealth services can now be delivered permanently in the home with no geographic restrictions, and audio only is now permitted on a permanent basis. Now, that is huge when it comes to rural access, disability access, transportation barriers, and people who are working and just can't take the time off to get the care that they need. However, broader Medicare telehealth flexibilities for non-behavioral health have shifted deadline dynamics, which adds uncertainty to the overall telehealth ecosystem. Now, what that means is right now, as insurance stands, you may not be able to get the access to some telehealth services that you need. Policy needs to fix this. The other issue is workforce shortage. Now, the United States, we can't just app our way out of a clinician supply issue, right? We can't create new apps. We can't all download Headspace and meditate our way out of a shortage. But it shows the HRSA reports that 122 million people in the United States live in a mental health professional shortage area. That is 1/3 of our population that lives in an area that does not have sufficient access to professionals to provide these services. This is an access bottleneck. Before we even talk about cost, we don't even have enough professionals to provide the care. Now, projections do point to major shortages across multiple behavioral health professions over time and projected in the future, which means if you are listening to this and you've thought about entering this field as a clinician or otherwise, we are calling on you to do so. It is unlikely for artificial intelligence to take your job in the near future. And we are not just in crisis for mental health, but we are in crisis when it comes to the developing workforce for new mental health care professionals. But let's talk about 988 crisis care line that I mentioned at the top of the episode. Crisis response is one of the most tangible shifts in the last few years. And in 2026, it's now part of our public mental health care infrastructure. Axios wrote a summary about an analysis that reported 16.3 million contacts, calls, texts, chats that spanned from 2022 through the end of 2024. That is a lot. And the research on crisis line outcomes suggests that many suicidal callers report that these calls are helpful, They are life-saving. It is preventing people from taking their life. Now, as we move into 2026 with new emerging technologies and interventions, people are constantly talking about new mental health tools, and there's a tendency to think in extremes. Either this will fix everything, or this is some sort of dystopian nonsense. The reality in 2026 is much more boring and more useful, to be honest. What we're seeing is diversification. We're not seeing replacement. There are digital mental health tools, and we're talking beyond teletherapy. We're now in what I'd call a second generation of digital mental health tools. Now, this first wave is probably what we're familiar with. We're familiar with meditation apps and mood trackers, symptom checklists, helpful for awareness, but really limited for treatment, really band-aid solutions or long-term coping, but these do not solve the problems. This newer wave of tools includes measurement-based care platforms to really help support session-to-session treatment, flag risk, track symptoms. There's these new asynchronous therapy models where clients message clinicians between sessions and get support around the clock. And now AI-supported clinical documentation. This is really supporting clinicians in preventing burnout rather than actually replacing clinicians. Now, an important clarification around artificial intelligence that I think we need to talk about is that AI is not diagnosing people. It is not delivering therapy independently in any legitimate care settings. When it's used responsibly in legitimate care settings like clinics, it's assisting clinicians, helping provide triage, documentations, reminders, risk flagging, bringing down and cutting down on that clerical and administration time so that the therapist can spend more quality time focusing on their clients and interventions, not acting as a therapist itself. This matters because burnout is one of the biggest threats to mental health care access right now, not on the client side, but on the clinician side. Tools that help clinicians stay in the field longer may quietly be some of the most impactful interventions of this decade in addressing mental health care shortages. Now, we need to talk a little bit about non-traditional biological interventions. These are the new tools that we talked about, but now we need to talk about the biology side of things. Now, we have normalized in the last couple of years conversations around treatments that used to sound fringe. One of those is transcranial stimulation. There's a new at-home brain stimulation device for depression that has recently received FDA approval. This signals a broader acceptance of neuromodulation as a middle ground between medication and psychotherapy. This is not a miracle cure. This stuff works best for treatment-resistant depression, people who don't tolerate medications well. There's also an increased awareness and interest in ketamine-assisted therapy. Ketamine clinics are no longer new, but 2026 has brought more scrutiny around the clinical oversight of ketamine-assisted therapy, integration of other therapy modalities and approaches with ketamine-assisted therapy, and focusing on the actual long-term outcomes of this type of therapy. Now, the early Wild West sort of phrase is cooling around this, which is good. Ketamine can be effective. There's evidence that supports it. But without proper integration with long-standing evidence-based treatments and proper safeguards, these benefits fade very quickly. And that brings us to talking a little bit about psychedelic-assisted therapies. You know, a little bit less hype, more realism, but this is a big one that we need to address carefully in the field. By 2026, psychedelics are no longer the shiny objects that we thought they were a few years ago. They've faced many regulatory setbacks, specifically around MDMA-assisted therapy, and it's forced the field to slow down and clean up its science. That's not failure. That's maturation. That's us improving what we are doing as a field and improving our administration of proper evidence-based tools. What's becoming clearer here is that psychedelics may be powerful catalysts, but they're not cures. These outcomes Where these types of treatments depend heavily on screening, preparation, and integration. They are not appropriate for everyone, especially people with psychiatric histories. If someone tells you psychedelics will heal trauma forever, that's misinformation. If someone tells you they have no therapeutic potential, that is also misinformation. More work needs to be done in this area. Now, we have a lot of great work that's been done on community-based and non-clinical supports. One of the most under-discussed shifts coming into 2026 is the recognition that not all mental health support should live inside the medical system. We're seeing a increased investment at local and state levels in peer support programs, community mental health care workers, school-based mental health services, workplace mental health interventions focused on workload, flexibility, fairness, not just mindfulness webinars. This matters because a huge portion of distress is contextual, not pathological. Burnout, loneliness, and chronic stress don't always require diagnosis, but they do require support. So as we kind of wrap up on talking about all these different types of tools, the grounding principle that I would offer you if you're listening to this is that in 2026, mental health care isn't about finding the solution. It's about matching the right level of support to the right kind of need. Mild distress, maybe education, community, prevention. If there's moderate symptoms that are being presented, then maybe therapy, more formal coaching, structured support. And then any severe or persistent illnesses, this needs more integrated medical and psychological care models, inpatient continuity, or outpatient care. These new tools expand options. They don't replace judgment, assessment, or human connection. Now, I want to pivot and push back on a few points in the public discourse. The first one is this general claim that we're overdiagnosing everyone in the mental health care system. Now, I think this pushback resonates because it feels true in everyday life. People see diagnostic language everywhere. Social media content frames personality traits as disorders. There's self-diagnosis happening faster than normal assessment on Instagram, TikTok, other social media. There is legitimate concern here. Diagnosis has drifted culturally from a clinical tool to an identity shorthand. But here is the important distinction that I want to make for you. Overdiagnosis and overlabeling are not the same thing. Clinically, diagnosis is meant to guide treatment, determine level of care, and assess the risk and impairment of the individual. What we see in popular culture is different. Labels are being used as explanations for behavior, ways to seek validation, and shorthand for complex experiences. That doesn't mean that anxiety, ADHD, or depression aren't real. It means that clinical diagnosis requires context, impairment, and duration, not just resonant, not just vibes. So when people say we're overdiagnosing, what they're often reacting to is this over-identification, not over-medicine, right? Over-identification on social media, in popular discourse, not actual over-diagnostics in the medical system. And the danger of swinging too far in the other direction, dismissing mental illness entirely, is much worse than the discomfort of having to be more precise with the language that we use day to day. Now, the second thing I want to push back on is that therapy culture is making people more fragile. This argument tends to show up generally as nostalgia. People used to just deal with things. But what's usually missing from that comparison is what costs people to deal with things silently. Untreated depression, substance abuse, broken relationships, and early death. Still, the pushback isn't entirely wrong. Mental health language can be misapplied in ways that lower distress tolerance, frame any challenge as harm, and discourage persistence. The key fair, so the key clarification is this: therapy is not meant to eliminate discomfort. It is meant to increase capacity. Effective therapy helps people tolerate uncertainty, sit with uncomfortable emotions, take responsibility for change, and engage more fully with life. If therapy is being used as a reason to opt out of effort, out of conflict, out of growth, that's not therapy culture working. That is misaligned expectations with the true medical system. The goal of mental health care isn't comfort, it's functioning, resilience, and agency. Now, the next piece of pushback that I want to talk about is this idea that mental health care is political now. This pushback feels uncomfortable because it's partly unavoidable to talk about. Mental health touches schools, workplaces, healthcare systems, public funding. So when policy decisions affect who gets services, what services are covered, and how crisis care is delivered, people start reading into ideology, into the entire field. And the grounding point that I really want to emphasize here is that mental health becomes political when access to it is contested, not because the science itself is partisan. The danger is not you disagreeing with me. The danger is policy debates obscuring, clouding the basic reality that people are struggling right now. You can disagree on values, you can disagree on language, and you can disagree on systems, but you have to agree that untreated distress and psychological issues have real consequences. These early interventions matter, and crisis care genuinely saves lives. So when mental health becomes a proxy battlefield for broader cultural conflicts, the people most affected are the ones least equipped to navigate that conflict. So, next pushback claim: insurance parity isn't real. This pushback is grounded in lived experience, your lived experience. On paper, mental health parity exists. You have access if you have insurance. But in practice, people encounter limited provider networks. There's not enough people where you live. Opaque authorization requirements, meaning who knows how you get approval to see this person for this specific thing. Higher out-of-pocket costs, higher deductibles, limited number of sessions, and long wait times. This creates a credibility gap. When people are told that mental health care is available, but experience mental health care is technically covered, but practically unreachable, they stop trusting the system. The pushback is not cynicism. This pushback is pattern recognition to a system created to prevent you from accessing it. It explains why public frustration isn't directed at therapists, it's not directed at research, it's directed at the systems that gatekeep care. Our frustration when we think about mental health care is at the system. It is at insurance companies, right? Now, I've given some pushback on some different popular claims out there. The next thing I want to do as we talk about the state of mental health care in 2026 is to address some misinformation and myths. So we're going to do a quick run of several pieces of misinformation. First one: if something resonates, it's basically a diagnosis. This myth thrives because resonance feels validating. People hear a description and they think, that's me. That explains everything. That's why zodiac signs and the Myers-Briggs are so popular, however, are not based in any scientific or research grounds at all. The problem is that many mental health symptoms are human universals: difficulty focusing, emotional reactivity, social anxiety, low motivation when you're under stress. All things I've experienced, all things you've experienced at some time. Clinical diagnosis isn't about whether a description fits you. It's about the severity, the persistence, the impairment, the context. A diagnosis answers, is this significantly interfering with your life consistently across settings? Where resonance, when you're just watching a video, says, does this sound familiar? Do I relate to this? Relating to something is not grounds for diagnosis. And social media blurs that line, not out of malice or anything like that, but because the nuance doesn't travel well in short form content. Now, the next myth and piece of misinformation I want to tackle is that medication's fake or therapy is just talking. These myths sit on opposite ends of the same misunderstanding. Oversimplification of treatment. Medication is not magic, and therapy is not just a conversation. Both of them require correct diagnosis, appropriate matching, time, and consistency. When people say meds didn't work for me or therapy didn't help, those experiences are valid at the individual level, but it does not invalidate the entire category of care. What you experienced was inappropriate matching, potentially incorrect diagnosis, also not enough time or consistency with the appropriate matching. What this means is wrong dose, wrong approach, wrong time, and insufficient support. Mental health care isn't just plug and play, show up, get answers. It is iterative. It takes time. The next myth I would like to tackle is that 988 and crisis care does not help. This myth often spreads through anecdotal evidence. Well, someone I know had a bad experience. That matters. No crisis system is perfect. But the broader evidence shows that there is a high utilization of these services and a high reported helpfulness, reduced immediate risk for many callers. The more accurate framing for this is that 988 is not the solution, it's a safety net, right? It is crisis care. It does not replace long-term care. It does not fix systemic shortages. But in moments of acute distress, crisis, it can be the difference between escalation and stabilization. It can be the difference between life and death. The next piece of misinformation I want to tackle is that youth mental health is only getting worse forever. This myth is emotionally compelling and statistically incomplete, to be honest. Youth mental health indicators remain concerning. Let's be honest about it. But the recent data do show some improvements, which tells us something critical. Interventions can work. Investments in the right place can work. If we frame youth mental health as an unstoppable collapse, what we are going to do is we are going to undermine prevention. We are going to discourage investment, and we are going to normalize the despair. We cannot fix something if we have not tried something. I think a more accurate message for this is that the problem is serious and the problem can be solved through action. So, in 2026, the biggest threat to mental health is not awareness. We have moved beyond it. We are aware as a society. The biggest threat to mental health in 2026 is confusion. Confusion about language, about limits, about how these systems work, what care is evidence-based, and what care is actually for. So, where does that leave us? Mental health care in America is simultaneously more visible than ever and more technologically flexible than ever, but still limited by workforce shortages, insurance barriers, and massive amounts of misinformation. If you take one thing from today, please do not confuse the discourse with the reality. The online argument isn't the same as what people need. People need accessible, competent care. And a culture that can hold two truths at once, mental health is real and mental health language can be misused. If you found this helpful, we'll keep doing these State of the Field episodes, short, evidence-grounded, and practical. If you want the resources, check the show notes. And again, if you're in crisis in the US, call or text 988. Before you go, if today's episode helped you think a little more clearly about where mental health actually is in 2026, the best way to support this work is simple. If you could take a second to like this episode, subscribe to the podcast, follow us on Instagram, I'd greatly appreciate it. It genuinely helps more people find thoughtful, evidence-based mental health conversations in a space that's often very loud and very shallow. If you want to support Ego Over Id as we launch, we've got something tangible for you. Our Ego Over Id enamel pin is available now. It's designed to be a small reminder that understanding yourself is not about labels or extremes or perfection. It's about awareness, balance, and growth. Every pin directly supports the show, the research we share, and our mission to make psychology accessible without oversimplifying it. You can find the pin and everything else at egoid.org. We'll link it in the show notes. Thank you for being here. Thank you for thinking critically with us. And we'll see you on the next episode of Ego Over Id, the Psychology of Everything.